My name is Eric Hummer. I'm a PharmD candidate at the DuVille College School of Pharmacy. I'm here to talk about my Journal Club article entitled Crizotinib versus Chemotherapy in Advanced ALK-positive Lung Cancer. The authors are Shaw, Kim, and Nakagawa et al. The source was the New England Journal of Medicine. The primary outcome measures was the progression-free survival of patients. The secondary outcome measures are the overall survival, response rate, both partial and complete, safety, and patient-reported outcomes. The design, it was a prospective randomized phase 3 intent-to-treat open-label trial. Patients were randomized in a 1-to-1 ratio into either the Crizotinib group, where they would receive 250 milligrams orally twice a day in 3-week cycles, or IV chemo group comprising either pemetrexed, 500 milligrams per meter squared of body surface area, or docetaxel, 75 milligrams per meter squared body surface area every 3 weeks. Patients in the chemo group were given pemetrexed unless their tumor had predominantly squamous cell histologic features or their prior therapy had contained a pemetrexed. Patients were stratified according to the ECOG performance status, 0 or 1 versus 2, the presence of brain metastasis, and prior or no prior therapy with epidermal growth factor receptor kinase inhibitors. Treatment continued until RECIST-defined disease progression was documented, an unacceptable toxic effect had occurred, or patients withdrew or died. The inclusion criteria: patients 18 and up with locally advanced or metastatic non-small cell lung cancer, positive for ALK rearrangements, progressive disease after 1 prior platinum-based chemo regimen, or measurable disease as assessed with the use of the response evaluation criteria in solid tumors, RECIST, and an ECOG score of either 0, 1, or 2. There were no specific exclusion criteria mentioned in the article. The study period, patients were randomly assigned between February 2010 and February 2012. 4,967 patients were screened, and 347 were randomized. 173 patients were put into the Crizotinib group, and 174 put into the chemo group, with 99 being put into the pemetrexed arm of that group, and 72 being put into the docetaxel arm. The study ended on March 30th, 2012, after the pre-specified number of progression events or deaths had been reached earlier that month. Monitoring. Patients had baseline tumor imaging, including both brain and bone scanning, done at baseline. Tumor assessments were done every 6 weeks until RECIST-defined disease progression had occurred. Patient-reported symptoms, functioning, and global quality of life were reported at baseline, day 1 of every cycle, and the end of treatment via a verified questionnaire. The scores on the questionnaire for the symptoms were ranged from 0 to 100, with a higher number meaning more severe symptoms. There were also 0 to 100 on the quality of life scale, except the higher scores meant a higher quality of life. The efficacy analysis was done on an intent-to-treat basis. Power was set at 90%, requiring 217 progression events or deaths to occur in order to detect a 56% improvement in progression-free survival with Crizotinib as compared with chemo. Alpha was set at 0.025. Progression-free survival is defined as the time from randomization to a progression of disease or death. The investigators used the Kaplan-Meier method to estimate progression-free survival and overall survival during the study. The results. Of the 347 patients that were randomized, 227 had had disease progression before the time of data cutoff. Median progression-free survival was 7.7 months in the crizotinib group as compared to 3.0 months in the chemotherapy group. At the time of the data cutoff, 96 patients had died, 49 of them being in the crizotinib group and 47 being in the chemo group. At the end of the trial, 85 in the crizotinib group, 85 patients were still receiving treatment, and 28 patients in the chemo group were also still receiving treatment. The tolerability. Most common adverse events in the crizotinib group are as follows: there were vision disorders, nausea, vomiting, diarrhea, constipation, elevated liver aminotransferase levels, edema, upper respiratory infection, dysgeusia, and dizziness. The most common adverse effects in the chemo group were fatigue, alopecia, and rash. The author's conclusions. As compared with standard second-line chemotherapy, treatment with crizotinib resulted in significantly higher or longer progression-free survival, significantly higher response rates, a significant reduction in symptoms, a significant improvement in global quality of life, and overall crizotinib was found to be more effective than pemetrexed or docetaxel in this study. The strengths of this study included the power being set and met, the biostatistical tests were appropriate for the study, valid outcome measures, they had adequate inclusion criteria, patients were randomized, an appropriate length to show effect of the drugs, appropriate treatment regimens for the drugs, and the author's conclusions were supported by their results. Limitations included the exclusion criteria were not clearly defined in the article. There was no blinding, and the study was designed by the sponsor, Pfizer, so there may have been a little bit of bias there. The level of evidence overall, I would say it is a level 1 with major limitations, going with the blinding there. A recommendation. Based on the results of this study, I would recommend the use of crizotinib over pemetrexed or docetaxel for the treatment of advanced ALK-positive lung cancer based on the following justifications. Of the 347 patients randomized, 227 had progression. The median progression-free survival of the crizotinib group was 7.7 months, and the chemo group was only 3 months. That's pretty significant. The safety, most of the adverse events experienced in the crizotinib group were non-serious, such as the nausea, vomiting, diarrhea, constipation, except for the elevated liver aminotransferase levels. That was a serious adverse event that they experienced. The cost, the crizotinib for a month's supply of the crizotinib, it was $13,000. For one dose of the pemetrexed, it was $3,500, and the docetaxel, 20 milligrams per ml, is around $365. For special considerations, the crizotinib did do a better job, but it is very expensive and may not be affordable to most patients, so perhaps a cheaper alternative might be better for those patients. And the study was created by the sponsor, so there may be bias there, so they might consider having someone else design a different trial to maybe make it less biased and get maybe better results. That's all I have. If there are any questions, feel free to email me. Thank you.